I'm going to discuss modeling high dimensional data, or a lot of people refer to this as big data lately, and the corresponding statistical methods that are best suited to analyze these data sets. We'll cover how machine learning techniques are powerful, informative, and have the potential to shape the future of healthcare, but also discuss how they're not immune to bias. And acknowledging these limitations is really important to the integrity of the research being conducted. And throughout the talk, I'll also highlight how including factors such as social determinants of health are essential in understanding disease complexity. Big data has received a lot of attention recently, especially in the healthcare space, and it's usually described in terms of 4 V's: volume, relating to the amount of data collected; variety, in the different types of data collected; velocity, the speed at which data are collected; and veracity, which is ensuring the accuracy and quality of the data, which I would argue is the most important, but often the most difficult. And the goal of big data is to discover associations and understand the patterns in the data. And the hope is to really inform the physician and patient during the decision-making process to help determine the most appropriate treatment option for that particular patient. So how can we best harness this high dimensional or big data to inform our understanding of the disease process? We'll discuss 3 different areas. The first is instrumental variables to measure the causal effect of exposures on disease risk. And we heard a little bit about genetic risk scores from Dr. Galea in the population context. And then we'll talk about machine learning to classify subgroups of disease and predict outcomes. And lastly, understanding potential biases inherent in different data sets. And I'll also note that my focus of study is on autoimmune diseases, and so many of my examples are going to include these conditions, but the methods can easily be applied to study several other types of chronic diseases, and actually come from literature on other chronic diseases. So first, let's dive into instrumental variables. So most health-related studies aim to answer causal rather than associative questions. We want to ask, what is the effect of drug X on outcome Y? But traditional statistical analyses usually only examine associations, looking at the association between X and Y controlling for W. But there are study designs and methods that appropriately address confounding and allow us to measure the causal effects. We usually consider randomized controlled trials the gold standard for study design examining causal effects, but we need to remember that they're not always possible, they're expensive, they're not always representative, and randomization answers our primary outcome only, and if we're examining a different outcome from the data, this randomization is broken. And there's been a lot of recent attention lately in using observational data to simulate or emulate randomized controlled trials, using more representative data sets. So there are statistical methods to assess causal effects with observational data, and these include instrumental variables, a subset of which is Mendelian randomization. There's G computation, inverse probability weighting, and several other different types. But today we're going to focus on instrumental variables, specifically Mendelian randomization, which is basically instrumental variables using genetics, a genetic risk score. In instrumental variables, we take advantage of instrument Z that is associated with exposure X. So the instrument Z must only be associated with the outcome through the exposure. So there's no direct effect of Z on Y. And the instrument must not be related to other factors that affect the outcomes, such as W here in the figure. If these assumptions are valid, a causal effect can be estimated from the data. As I mentioned, Mendelian randomization is merely a type of instrumental variable using genetics, and it takes advantage of the random assignment of an individual's genotype from his or her parental genotypes that occurs before conception. And this randomization by nature can be thought of as a randomized controlled trial and exploited to make causal inferences. For an example on Mendelian randomization, I'll walk you through a project which focused on obesity as a risk factor for multiple sclerosis, or MS. And previous studies had shown that obesity was a risk factor for MS. But as we know from Dr. Galea's presentation and life course of research, obesity is very complicated. There could be other factors that associated with obesity and self-reported weight, which also are independent MS risk factors that could be confounding that relationship. So things like physical activity, diet, socioeconomic status. And so really a self-reported obesity in observational studies really could be a proxy for so many things. And so our goal was to use Mendelian randomization, or genetic representation of obesity, to measure the causal effect of BMI on MS. We constructed a BMI genetic risk score using 97 variants associated with BMI from a large external genome-wide association study. And the score is calculated by summing the risk alleles and multiplying them by their estimated effect on BMI, and then summing across all 97 variants to create a single weighted score. And as we heard in the previous presentation, this is across the population. So individual risk by person doesn't really represent much, but on a population level, we can look at the causal effect of obesity. And because there are such small differences for things like instrumental variables or Mendelian randomization, you really need a large sample size to be able to measure an effect. After all, a BMI genetic risk score only explains about 2% of someone's actual BMI. So it doesn't negate its power as an instrument, it just means you need a really big sample size. So in this study, we had over 6,000 cases and 15,000 controls using a data set from Kaiser Permanente in Northern California and a secondary data set from Sweden. And we found that in both data sets, and then we went on to create a combined odds ratio, we saw that BMI was causally associated with multiple sclerosis susceptibility, which solidified that BMI itself plays a causal role on MS disease onset, apart from any downstream potential confounders. And I won't get into it here, but then we also constructed a childhood BMI genetic risk score to kind of try to tease apart adult versus childhood BMI. And while we found that childhood obesity was very strongly correlated with adult obesity, it was really that obesity later on in life that was significantly associated with MS risk. Beyond genetics, there are many types of instrumental variables that are used in research, especially with respect to local, state, and federal policies. And one can use these policies to look at factors such as social determinants of health. For example, literature has used state SNAP policies to look at food insecurity or travel distance or time to clinic for healthcare utilization, and changes in how co-payments are covered to look at medication adherence. And there are several other examples of instrumental variables to look at social determinants of health. So I encourage you to think about these types of analyses beyond genetics. So in conclusion, instrumental variables can be utilized to measure the causal effect of an exposure on an outcome using observational data by eliminating potential confounding. And there are many options for genetic and non-genetic instrument, but as I mentioned, they often require large sample sizes. And applying causal methods to big data can help inform mechanisms of disease, which will better inform treatments and interventions across the population.